This is an educational video that we'd like our patients to view, and the purpose of this video is to provide a patient with the information they need to successfully go through a knee replacement, and particularly the week before and 2 weeks after. And I'd like to introduce Tim Heckman, who's our head therapist, and Michael, who's our patient. And Michael, you have an incision that's very conspicuous on your leg, and you had a knee replacement how long ago?
I had a knee replacement 2 weeks ago yesterday.
2 weeks. How are you doing?
I'm doing awesome. I'm doing so good that I'm scheduling with Donna my next knee replacement in June.
And you mentioned that as a patient, probably, what was the hardest thing beforehand?
I think the hardest thing was just the apprehension of not going through knee surgery before. And once I went through it, it's a new area.
Right.
That's correct. And it's just the unknown, really.
And there's a lot of scary things that go through your mind.
There are a lot of scary things, sure.
And my job as your shepherd is to kind of get you through that and let you know that you have some very experienced people and very experienced professionals. And I wanted to talk a little bit about that because that's what patients always ask me, and maybe this video will help them kind of understand a little bit that they're going through a very, very scheduled series of events. I always say I'm a 747 pilot, and just like a airplane taking off, you'd be surprised as a patient all the little events that occur beforehand. And one of the first events is I like my patients to take vitamins before surgery.
Right.
I want to make sure that they are in good health. And if you have any infection in your urinary tract, any problems with your teeth, any infection at all, we don't want to do the surgery. We want to get you in the best health possible. We want you to see your family doctor beforehand.
That's correct. I did that. Yeah.
And so this is an event that we want you to do all the planning beforehand. Occasionally we'll find out if the patient is anemic, and so they may be treated with iron. The second thing that we want you to know is that we have many different things to prevent infection. And I think I probably mentioned some of those to you. And infection is just a disaster when it occurs with knee replacements. It occurs about 1% of the time, maybe 2% of the time. Patients that have diabetes are a little bit at an increased risk for infection. Smoking, we don't like smoking. And I will insist that the patient be off any smoking or any tobacco use at all. And that wasn't the case with you, so we didn't have to.
That's correct.
We didn't have to worry about that. We also want you to know all your medications that you have. When you come in, there are certain medications that you can take.
Right.
And you just take them right through the operative procedure in the morning of surgery. So we're very, very specific on that.
You have been.
And then the other thing that's very important is you do have to be on a blood thinner.
Yes.
And the reason you're on a blood thinner is that about 10 to 20% of the time you can pick up a clot in your calf. And of course we're concerned that that clot may go up into your lungs. And so you do have to be on a blood thinner. And there are many different programs for thinning the blood. We happen to use Coumadin, and we monitor that very carefully. There's 3 different programs, and I really wasn't going to go into that in great detail, but you are on a blood thinner, and that's being monitored, and very soon you're going to get off the blood thinner.
That's correct. I just came off it yesterday.
And when you're on a blood thinner, I always remind our patients that you can't take lettuce and you can't take spinach, and you probably heard that.
I did.
Because that potentiates the Coumadin.
Right.
And then the other thing is I like our patients to take yogurt. And the yogurt is for the bowels so that the strong antibiotics that I give you don't disturb your system. So, and we also want you off all aspirin.
Yes.
And any of the aspirin products or any of those that might change your platelets. So those are kind of the general rules to get ready for surgery. One of the things that people always ask me is how do I go up and down stairs? And that can be a problem. And Tim, I'm going to have you address that in a minute. And in fact, why don't you address that right now? What do they ask you before surgery? What you can do and what you can't do?
Well, part of what they do inquire about is, are there things that they can be doing from a strengthening standpoint or an exercise standpoint ahead of time, and so that we do attempt to have the patients be seen at least one time prior to surgery, so that we do have an opportunity to evaluate their range of motion, evaluate their strength, and then to try to set them up on an appropriate exercise program. We try to find out if they've walked on crutches or used a walker or a cane before, because those are things that they're likely to encounter after surgery. Patients that are concerned about their balance, stairs then become a big concern for them. So using the railing, potentially having a crutch under the opposite side. We teach the good go up, the bad go down, which basically indicates which leg you would lead with going up the stairs or down the steps. So
tell me that again. The good go up and the bad go down?
The good go up to heaven, the bad go down to
I'll remember that.
The other. And so it then just dictates the non-surgical leg is what leads to power you going up the step, and then the surgical side then trails. So the patients are then going one step at a time, being stable on one step before they then move up to that next level. And then coming down steps, they would lead with their surgical side, and it's their good leg or non-surgical side then which controls the body weight moving down. Their involved side goes down, their body weight then is being controlled by the non-surgical side, and again the railing or the banister or a crutch or assistive device can be used to then help stabilize the balance until you get down to the next step.
So those are important things. I mean, the worst thing you can do is to fall on the stairs, and you're always keeping your stable leg when you're going up and down the stairs is what you're doing. And just to listen to you, you can see what happens when a patient doesn't get to go to you as the therapist beforehand, and how difficult it is for patients to come in after they've had surgery. Maybe they're in some pain, they're in some discomfort, and they're seeing you as a strange person, and you're now trying to pick up all those pieces. So I can't emphasize enough the importance of that rehabilitation team and what you're doing ahead of time. It also makes the patient, I think, feel a lot better because they know what they're.
That's right.
Who's going to be there afterwards?
Yeah.
And
familiar face.
The familiar face, and that they're going to take care of them. I imagine it's a little bit hard for you to do very much strengthening because I'm doing the surgery and they're having pain in their knee. So you're really more concerned about showing them what they're going to be doing after, aren't you?
Correct. Again, if we can have a chance, 4 or 6 weeks ahead of time to meet with them once, to then set them up potentially on an exercise program. We meet with them the day before surgery to review their instructions on what to expect. Again, I think one of the things that I've noticed over the last year or two is that I don't think that the total knee replacement is given its proper due, meaning that total joints have become so commonplace that patients don't estimate how much of a challenge the surgery is and then how much of a challenge the postoperative rehabilitation is. And so they're surprised at how hard or how difficult, how much they have to work to sometimes get to be able to walk normally, to get enough bend in their knee, or many times to be able to get their leg all the way back out straight. So that time ahead of time gives us a chance to try to further educate the patient.
And you mentioned something about that. It's a big commitment.
It is really a big commitment, but I think that a very, very important part of the whole process is not only having an expert like yourself do the surgery, but also the rehabilitation. And really training the patient right away. It was lucky that I came from out of town, from Washington, D.C., because I had to stay here for 2 weeks. And I was able to have the therapy on a regular basis for that 2-week period and get into a routine. But I can see where people, if they go back home out of the therapy program, they don't have that discipline and that consistency and the support.
Yes, and there really is. We love therapists. We've trained so many, and therapy is just the major part. I spend 2 to 3 hours with you, and then he's got to spend months and months and months to get the function back. And there really is a knee specialist after. The therapy is very, very specific for the knee, and there are very specific things that you have to do. If we move now into when you went to the hospital,
Yes.
when you go into a pre-anesthetic area, and you're
That's correct.
greeted, and you get ready, and the nurses are very nice there.
They're awesome. Actually, it was a really nice environment. It was a really high quality, really super, hospital. And they were very, very kind, and they were very careful from the standpoint of educating me as far as what to expect. And the way that I was handled, it gave me a lot of comfort going in.
Good. And then you go from there into the operating room.
The operating room.
You get to see me and my operating
For
gown
just a little bit, I'm on the happy gas by that point. And
then you go to sleep.
And I go to sleep, and I woke up, and I was, sitting in a bed, and I felt really good. I felt nice and relaxed, and I was very, very relieved that everything went really, really well.
We have a fabulous post-anesthetic recovery room, and that recovery room is a very important part of your surgical experience, because you're waking up and you have someone right by your side, and if you're having a little pain or you're having nausea, you don't realize it, but that medication's going into your intravenous line.
Yes.
And they're taking care of you, and they're monitoring that whole process. And I'd like you to be in the recovery room for a relatively long period of time. We don't like to discharge you from there and up to the floor.
Okay.
So we like that real intensive treatment that you get right after. Then after that, you go up to the floor.
That's correct.
And how soon did you get out of bed? Did you?
Actually, what I did was after I spent the first night there, I was really up and around a little bit the very next day in the morning. So they had me sitting up in bed and moving over to a chair and sitting up. I mean, they were right there to assist me so that I couldn't fall, but they strongly suggested that I get up right away. And I was feeling so good at that point that I even thought maybe I should think about just checking out. And then I thought about it a little bit more, and I said, well, I'll spend another night, which I did. And then there was a lot more activity that second day as far as moving around.
Now, in terms of pain control, we have different levels, and I tell the patients beforehand that we start right at the time of surgery. And Michael, you don't realize it, but while you were asleep, we put in a really nice block all the way around your knee. And that block then really numbs the knee area. And so when you wake up, you're not experiencing that real,
I did not have any pain.
Sharp pain.
Yeah, I thought there would be.
And that's good.
And there wasn't, yeah.
And as a matter of disclosure, I have to tell people that that's about 90%, but about 10% of people will have pain. So the next level up on that is to do a nerve block, and that's where some Novocaine is placed into your nerve. And then the next level up from that might be narcotics or other medications. So we have all these different levels to keep you comfortable. And you've been a great patient. I mean, you just flew through this experience. I wish that every patient would be as good as Michael. And I do have to again say, Tim, for every Michael that we have someone that's not going to progress as fast as Michael has. So we're kind of showing Michael off because he's such a good patient.
Well, I think part of it, though, is really, you really provided great pre-surgery and post-surgery education. Young children are afraid of the dark. Adults are afraid of the unknown.
Yes.
And you provided a lot of very, very good reading material, educational material. And I was really at peace a little bit at home before I came in when I saw the care that you took with respect to eliminating the potential for infection. You asked us to go to a drugstore 5 days before surgery and buy a liquid to bathe instead of soap for that 5 prior days. And there were a number of other things, and that really gave me comfort knowing that,
So let's spend a little bit more time on that, because that was one of the things I wanted to mention. As I mentioned, infection is a disaster when it occurs. So what do we do for that? Well, you mentioned the body wash. We want that body wash for 5 days, and that's with Hibiclines, and that really, really cleans your skin, and that's very important. Second, we get a culture of your nose. We look for any bacteria in your nose.
That happened the day before,
Yeah, and that can be MRSA. And so if you have any bacteria there, we're going to treat that. The third thing is you get very large antibiotics, large dose of antibiotics right before surgery.
Right.
And that's running around your body right as I'm doing the surgery, but then you do not get it the next day because we don't want to produce a super infection. What you are not aware of is that we irrigate the wound with an antibiotic, and that's done throughout surgery. We keep it very moist. That does have an antibiotic in it so that we can also kill any bacteria. And then the final thing that we do is that there are antibiotics placed in the cement in the total knee joint. And those will stay in the knee joint for a period of 2 to 3 weeks. So I'm glad you mentioned that. And that's a really great program that we've introduced, and many hospitals have introduced that. And then the final one, we do all of our surgery at Jewish Hospital. There are many fine hospitals in this area. We do it at Jewish Hospital, and we have total just knee rooms and shoulder rooms, and all of those are just dedicated to orthopedics, and they have very good infectious control there. So that's a whole process that we share with our patients so that they can feel comfortable about that and know that a program is in order for that.
I was also impressed when, I think it was the second day that I was there in the morning, and somebody came in and said, oh, you should remove the dressing. And they said, oh no, this is Dr. Noy's patient. They do not want any of that dressing removed unless it's their own physical therapy group. And that's another...
Good for them. They're following rules.
They know. Another way to minimize infection.
Yeah, that's right.
I was very impressed with that.
Yeah, good. Well, Tim, you now have Michael, and just to complete this last 2 weeks, Michael is here with you, and you see him after surgery.
Right.
And I guess the first 3 or 4 days, we're going to expect some swelling. We want ice, elevation. Do you want to kind of go through what you do in maybe the first week and show some things, and then we'll talk maybe about what you do in the second week.
Sure. I mean, as Michael said, you know, when the patients come back, they're released from the hospital. They'll come for their first post-operative appointment with us. We will be responsible for taking the bandage and the dressing down, cleaning his leg, and then placing him in his TED hose. We talked earlier about blood clot prevention. As long as the patients are taking their Coumadin or their blood thinning medication, they will be wearing a TED hose on both legs.
Which I did, right.
Part of that is for that process. Part of it is for the surgical leg for swelling control. Typically, an increase in swelling will likely increase the patient's pain as well. So we do want the patient periodically getting in that elevated position, getting off their legs, ideally getting their foot higher than knee, higher than their hip, and allowing support to really run from foot or heel to hip. We try to avoid having the patient put something solely underneath of their knee.
No pillows underneath
of the knee.
I was given a lot of instructions.
We try to warn that the patient that the position of comfort is flexion, that their knee is going to want to draw back up into flexion. They're more comfortable that way. One of the reasons that I think that we sometimes have an opportunity and desire to see the patients preoperatively is to evaluate their range of motion at that point so that we know if they lack motion, then we can go ahead and begin to implement those instructions. So in the hospital right away, we can put them in an elevated position and bring their heel up so that their calf muscle elevates up off of the surface of the bed or the mat or whatever they're on. So there's room for the knee to now drop down or to relax down into the extended position. So that's something that we'll identify preoperatively, whether or not that they lack motion, and then begin to instruct them in the hospital already. That's certainly something that's carried out as a part of their immediate post-operative program as well.
Right away.
And I might just say from a surgical standpoint, I get the knee straight, and of course the patient is asleep and the muscles are relaxed. And most patients do not have the ability to extend their knee. It's locked because of the arthritis, so they can't extend the knee, and then just straighten your leg out, just straighten it out. So a lot of patients will come in and they lack 10 or 15 degrees. I get it straight, but then you've got to keep it straight with the patient because the muscles in the back want to contract down. And to get a good knee, we have to get full extension, don't we?
Right. And we do feel that, again, that lack of extension. And some patients say, well, gee, I haven't had it for a year, 2 years, 5 years. Well, again, part of the function of getting extension is to bring that limb length back to neutral or to full extension, so that we take some of the pressure off of the foot and ankle, and we take some of the pressure off of the hip and back as well, so they don't develop secondary problems above and below the knee joint.
One of the things that really helped, that enabled me to keep my leg straight through therapy, even though it has a natural tendency to pop back up, is Donna had offered to provide us a ice machine that you recommended that was relatively inexpensive, and it's so easy to use. And by using that on a regular basis when I was at home, I didn't have the swelling, so you didn't have the stiffness that wouldn't allow you to keep your leg straight. So that was very helpful.
I'm glad you mentioned that, Michael, because I don't know why, but Medicare does not pay for that ice machine.
Oh my God, that's the most valuable, inexpensive investment in the world.
In sports medicine, ice, ice, and ice. Yeah. So you were very smart to get that, and I encourage people to get that ice machine.
It does allow a very uniform level of cold. The bladders only come over part way, so we still encourage patients to use an ice pack or a cold pack underneath to get circumferential cold to the entire joint. So the ice compression elevation within that first week is critical.
And ankle pumps. You want to do your ankle pumps?
Oh my God, I did. I've done thousands of them. I think I do them in my sleep now.
Yeah, we like ankle pumps, and we like you every hour to do 10 or 15.
I do about 150, 200 a day.
And that keeps the circulation going, and very important. So that's really the first week is a little bit hard on patients, isn't it? And I think a lot of patients don't realize that they can have a moderate level of pain. And that's where we come in. And many patients will be on narcotic medication for 1 week or 2 weeks. And by 2 weeks, we hope that that pain is getting less. I will say that what you mentioned to me before, patients don't realize the commitment. And I tell them, you've got 6 weeks of really working hard.
Yeah, very focused.
Very focused, and all the problems occur in that first 6 weeks.
Yeah, both my parents had both of their knees and their hips replaced, and they're in their 80s now, so I saw the commitment that was needed, and it ended up great for both of them, and really enhanced their lives tremendously, but there was a real commitment. So I didn't come in here with false expectations about no pain and no commitment. I knew. Actually, my expectations were it wasn't anywhere near as bad as I thought it would be, because I had high expectations as far as pain and commitment.
Good.
Yeah.
So Tim, we've got extension, and you've got a weight there. Do you want to show them how you use that and what they have to do at home?
If the patient by the end of the first week hasn't gotten back to full extension, then we will start a gentle overpressure program with them. So even in this case, within that first week, and working with the elevation, we're still trying to set the tone for a process. And so we encourage them to prop their leg 6 times a day for 10 minutes at a time. I like that first thing in the morning, as you made mention earlier, to again, get the leg straight right away. And then I also like to have them do it last thing before they go to bed. So again, it makes it a little bit easier when they go to fall asleep, because we know during nighttime and during sleep, the knee is going to start to return to a position of comfort. So that 4 to 8 hours of sleep time, whatever the patient is utilizing, we want to kind of frame that with getting the leg straight. And then we encourage that intermittently and evenly throughout the course of the day in order to get that motion. If they can't get that with just the effect of gravity and some gentle stretching, we will look at doing and performing what's called a hanging weights program. So again, the patient's placed in this same elevated position, and then we'll start with an ankle weight that's placed over the lower portion of their thigh. Try to watch that I'm not getting a lot of direct pressure over the top of the kneecap, but you really need to get that weight as close to the joint line as you can. And now you're using this additional weight plus gravity. Many times the patients have to be coached as far as their breathing patterns and relaxation, because the patients do want to splint and guard or contract their muscles to fight the amount of weight that's on there.
How much weight do you have on that?
Right now I have 10 pounds.
And how does that feel with 10 pounds? Is that,
it's fine. I mean,
it's fine.
Yeah, I'm at the end of 2 weeks right now, so I don't know how it would feel after a day, but yeah.
So most patients can really tolerate at least 5 pounds, 10 pounds, and then if there's a problem, you'll actually go up even a little bit higher.
We'll go up to 20 to 25 pounds, depending on the size of the patient or, again, the degree of difficulty that we have. If the patient can achieve extension but they have trouble holding it, then that lets me know that I'm close to the amount of weight that they need. It's when we start with 10 and they can't get there, then I know that 10 pounds isn't enough, and we have to start staging that up right away.
Great.
So let me just summarize that. That's such an important thing because we don't want the patients to lose extension. So coming into surgery, Tim can identify if you don't have full extension and you've got 10 degrees or 12 degrees, you're really going to have to work a little harder than someone else. And then secondly, the position of the leg. We don't ever like a pillow under it. We like to always use gravity. And then starting really the first week of surgery, you're going to start overpressure. And when you're with your therapist, he will get you fairly straight, but then you've got to keep that and go home.
Right.
And you've got to do it 6 times a day, sometimes 8 times a day. It's only 10 minutes, but you've got to set your clock and just start to get that extension. You can pretty much tell if your patient is working, can't you?
Yeah, most of them will own up to it, but there'll be some that will try to kind of buffalo and say, yeah, well, I'm hanging my weight some. But you can tell those that are, because as soon as we put them in that position, they just don't tolerate that very well.
Yeah. And now what do you do for the muscle education to keep your strength?
Well, there are a couple different things that we would look at doing. I'm just going to slip this out from underneath of Michael.
Sure.
Part of what we'll do is a quadricep isometric, quadriceps being the muscles in the front of the thigh, and something as simple as just asking them to flex or to squeeze the muscle, try to push the back of the knee down towards the table. I'll have them do that as an alternating exercise so they can use the non-surgical side to help compare to the surgical side. And then I can get them to do that with both legs at the same time so that, again, that we're using the non-surgical to help teach the surgical. That, to me, is the building block exercise. Electrical stimulation can be used to kind of help superimpose the contraction.
And you were doing that.
So that a co-contraction of stimulation plus the patient's voluntary contraction should be stronger than either by itself.
So the point I didn't mean to interrupt you, but the point is you want that muscle turned on the first few days right after surgery.
Exactly, because if they don't get that, then things like walking, trying to come off crutches, all the things that patients want to do quickly, those things don't fall in place, that there's delays that are put into place.
Tim, I'm always asked about continuous passive motion because we used to use that a lot 5-10 years ago, and I now call it continuous active motion. And really, rather than sit in a machine and just have it bend your knee and do everything for you, to me that's about one of the best ways to get atrophy of muscles. And what you're doing is you're teaching the patient to do it themselves, which really builds the strength that we need. So we rarely use the continuous passive motion.
I think what we found is that patients got lulled into a false sense of security. The machine was set at 0 to 90. They hit the ends of the machine, so they just assumed that they were at 0 to 90. The patient came in, we would measure them, they would be at 10 to 70. And the patient then compensates. All of a sudden now the machine is kind of askew to their leg, and so we've kind of gotten away from that and put a little bit more of the responsibility back onto the patient for active motion, where they bend and straighten the knee on its own, but also something that we've used is called well leg range of motion, where they can use the opposite side to help create that overpressure. And we'll demonstrate in a little bit with Michael out over the front of the table how he can actively extend, use his opposite side to help force out. If it doesn't go completely straight, bring it back down.
Why don't we do that now?
Okay. Well, as we talked about, active range of motion, active now being Michael bending and straightening his surgical side on its own. So I normally would have them pull their toes up and then ask him to straighten that leg as far as he can on his own. Squeeze, tighten the muscle, again to engage the quadriceps, and then to gently let that back down. So he's using his quadriceps to straighten, he's using his quadriceps to come back down. If he's at the 90-degree position and we're looking to go further, again, that concept of well leg, I can have Michael bring his left leg or his right leg over in front of his left, and then actually use
Gently
it to
push.
create gentle overpressure into the stretch position. So again, where we now start to stretch the distal end or the lower end of his quadriceps across the front of his knee. One of the other things that I like to do out over the front of the table is to make sure that his is gliding. You know, with a full open procedure like this, again, one of the things that happens is that those tissues can start to bind down, and so that he can start to lose a little bit of the normal, just let your leg relax now for me.
Sure.
A little bit of the natural mobility that's present, where I can have that glide back and forth. And this would be one of the things that we would do as a part of their therapy program.
Yeah, you did that every day.
And one of the things that we could potentially teach the patient, or in this case Michael, or Michael's wife, or one of his family members to kind of assist this. And this is an important component when you're working on trying to increase the range of motion, because if that starts to stick down, the patient loses that mobility, they'll ultimately lose range of motion.
That was really an advantage because my wife was here with most therapy sessions for the first week, so she knows how to help. When I get home and what the protocols are, she won't let me slack.
Well, you actually mentioned a very important thing, and I insist that the patient bring a family member in because they have to know the medications they're going to give you.
Yeah.
And really be your caregiver for a while, particularly for this first couple of weeks.
Right.
That patellar mobilization is really important from my standpoint, and I personally check that because, as Tim mentioned, if you get any scar tissue that starts to occur, and 10% of people will get scar tissue where they have to work a little bit harder than the next patient. And usually the first place we get the scar tissue is around the kneecap, and the second place we get it is in the back of the knee that's preventing extension like we talked about. So Tim, you obviously are monitoring along with me the swelling. We have medications that we use for swelling, and that can help a patient. The ice we've already mentioned. What about the gait in terms of walking? How do you teach them to get back to a good functional gait?
Well, preoperatively, we would have ideally an opportunity to check to make sure that their crutches or their walker fit properly, that they are sized proportionally. And then for somebody that had not been using those devices before, then we would take time during that preoperative visit to then instruct them on a level surface, but then would also take them into the hallway and then in the stairwell to teach them how to go up and down stairs as well.
Even though I can crutches through insurance or what have you, I was very impressed with the sensitivity of your staff in that they asked me first if we had crutches that we could bring when I first came out for the first appointment. You know, and then when I brought them with me, they sized them to be sure that they were, you know, fit perfectly.
Right. Yeah. I mean, one of the things that patients are told, and the benefit of having a total joint that has a cemented prosthesis, is that the patient can then start to put weight down on their leg right away. They're encouraged to do that in the hospital. They're encouraged by Dr. Noyes. In the hospital, they're seen by the physical therapy staff that will follow up, and then will then take over once they hit the outpatient setting.
Great.
Progression is really based on pain, swelling, the patient's ability to get full extension. Another reason that we monitor that closely, because we don't want the patient walking on a bent knee. And then their muscle control becomes a key as well, because the quadriceps or the front of the thigh, that muscle stabilizes your knee so the knee doesn't want to buckle or collapse during ambulation or during walking. And so they're taught, I kind of joke with patients that in this case, Michael's left leg is involved, that he would have 3 left legs. The crutches in his left leg will move at the same time, and then the right side will step through. We try to encourage a normal symmetric walking pattern so that the crutches are a part of the left leg and that they move in normal alternating sequence.
Well, Tim, that's very good. And I think just to summarize then what we've talked about, in that first 2 weeks after surgery, our goals are to always control pain, make our patients comfortable. I will say one thing, it's very important that they drink water.
Yes.
We've occasionally had patients that will stop drinking water and they get dehydrated. So,
drinking a lot of water.
You drink a lot of water. We want to make sure that urination is occurring. Some of the medications will cause constipation. So we indicate if they've used milk of magnesia or what other stool softeners, that would be an important thing for them to do. We want to encourage that they're not doing heavy meals. You know, you should be doing light meals, a lot of fluids, vegetables, fruits, and what have you, but you don't want to be out having a steak and until you really know that your plumbing and everything is working fine. So that first 2 weeks then, you need a caregiver to help you. We're going to decrease your pain, decrease your swelling. We have to restore your motion. We really want to get 0 to 90 degrees by the 2nd to 3rd week. And I mean, that's really moving along, and you're going to really assist them to do that. And then the muscle strengthening, because they're using crutches, but we're going to try to get our patient off the crutches just as soon as we can. Tim, the patient always asks me, when can I start to drive? And we've always kind of kidded them on that, and we say some people can't drive with 2 normal legs. But we can't really tell the patient when it's safe for them to operate a motor vehicle. You have to have 30 to 40 pounds pressure, so that's your weight bearing.
For the brake.
And then you have to be able to move your leg around and be able to control it. When would you say most patients can independently drive?
That's really going to be patient dependent. We've had patients, I'm going to say on average, by the 3rd or the 4th week. Some of them have returned. You know, we've been the extremes. In an emergency situation, probably as early as 2. I would say, you know, 3 to 6 weeks is probably about the norm. We talk about weight bearing. You mentioned the amount of pressure. We encourage enough range of motion to get underneath and out from underneath of the steering wheel. We want them to be able to tolerate their leg resting in that dependent or floor position, and they have to be off their narcotic pain medicine at least 4 to 6 hours prior to driving. And then we'll typically encourage them to find a school, shopping center, business, if they live in a quiet neighborhood, to do so without traffic to test what their comfort level. But we always tell them that, again, the party line is that you do so at your own risk. But we think that if their symptoms and their level of self-trial without traffic is good, that they have about as good an opportunity as ever.
Good. Well, I think you can see it's been a pleasure to work with the two of you and just kind of go through. We've only gone through 2 weeks here, Tim, and now we have another 6, 8, 10 weeks to go through. We want our patient coming in twice a week to be able to get the instruction. And really the intensive instruction that you give is really for the first 12 weeks, isn't it? By the end of 12 weeks, everyone has a smile, and we've now accomplished our goals, and people are doing it. So it's that commitment for 12 weeks. And you've been a good patient. Is there...
like I said, I saw my mother and father go through knee replacements, hip replacements, and then 7 years ago at a major medical center in the Washington, D.C. area, my leg went into septic shock because they didn't have the protocols they have here as far as minimizing infections. So I was in a very, very precarious position for 7 years before I finally decided to have the knee replaced. And so I was really ready, but I would just encourage anybody to really listen and to really follow your instructions, and I think everything will really go along pretty smoothly.
I think that's important, and we tell patients that they should ask every question, and they really want to ask the question of what is your program like, and what is it before surgery, and what is it after surgery, and are all of these control systems in place?
That is the key.
Well, I think
you could have a factory that does 1,000 or 2,000 or 3,000 or 4,000 knee replacements a year, but you have the total package, which is the discipline and the processes up front, top world surgeon, and then you've got the integrated physical therapy process afterwards. So you really, really do something here that very, very few places do, because it's all not integrated in other
we appreciate that.
service providers. Really. It's been a pleasure.
Thank you for saying that.
No, it's true.
So
very happy.
You came all the way from Washington, D.C. to Cincinnati. And
just for this, I took off 2 weeks of work so I could go through the physical therapy for 2 weeks, and I couldn't be happier. I really am.
Great. Well, thank you. Thank you all very much.
Okay.